We all have our fantasies. For guys, it might be, what's it like to hit against Nolan Ryan's 100-mile-an-hour fastball? Or driving 200 miles an hour as a race car driver? I would not prefer to do that, but guys do like sometimes something really scary but exhilarating. Well, did you ever wonder what it's like being a brain surgeon? I mean, literally touching someone else's brain and where the slightest mistake could be life-altering. You may have watched the TV show Grey's Anatomy and admire how cool and handsome the neurosurgeon Derek McDreamy Shepherd, aka Patrick Dempsey, as he scrubs into the OR. But trust me, it doesn't come close to what it's really like. My guest today, Dr. Theodore Schwartz, is the real deal. He's a top neurosurgeon and professor of neurosurgery at Weill Cornell Hospital in New York City. He just came out with a book, Gray Matters, where he describes very realistically what it's like to be a brain surgeon. And he also goes into the fascinating history behind the evolution of this field. I think the listeners will be stunned to find out how, in the early days, how primitive and maybe even barbaric the early days of brain surgery was. So I'm super excited to welcome Dr. Ted Theodore Schwartz to the podcast.
Dean, thanks so much for having me. And yeah, please call me Ted.
Okay. Well, first of all, I really do want to congratulate on this excellent book, Gray Matters. It was a really good, smooth read. Lots of personal revelations, which I think the readers will find, which we'll discuss a little bit. And honestly, though, but if your head publisher had called me ahead of time, I would have maybe suggested the title of the book, No Room for Error. And that's sometimes how I feel about medicine. There's just, I know in my practice, I always feel like there's no room for error. And for sure, in your OR, no room for error.
That's
So,
that's a great title. I think
next
that
one, the
definitely
next
could
one.
have worked. Yeah, we'll have
I
to
just have
get you involved.
I have one other quick question too. This looks like the headless horseman thing. Like, why this picture on the cover, like with that, missing the face? I'm just curious.
So I didn't choose that picture. The
Okay.
editors and the cognoscenti at Penguin Random House have a whole department that chooses
Sure.
covers. And when I first saw it, I was a little taken aback, but the more I looked at it and the more I analyzed it and thought about it, I actually love the cover because
Oh, I do too. Yeah.
it is a headless, faceless surgeon. But I mean, people have asked me, is that a picture of you? Are you on the cover? And the answer is no, it's not me. It's not my outline. And there's two reasons I like it. One is that the book is really about the field of brain surgery. It's not about me per se. I mean, I include memoir in it. And I felt I had to include some memoir in it to draw the reader in, to make it personal, to make it
You made
emotional,
it really
to
good.
bring
Yeah.
feeling into it, right? And to be a narrator that was sort of trustable and likable. So, it's really a biography of all brain surgeons because we all do these things. And the facelessness of it and the genderlessness of it to some extent means that it's really about all of us. And I wanted it to represent the field. The other thing I like about it is that I write, at the back end of the book, I address some philosophical questions about the nature of the self and our identity and how we think we are more in control of what we do and who we are than we really are. And I like the fact that the identity is missing on that surgeon, because in a way I'm trying to say that our identities are much more fluid than we think. The brain is much more in control of what we do and the choices we make than we are and than we think we are. So there's also that aspect of the
Yeah, I hope to
headless
get to that
faceless.
later on. Yeah, that's like really a very higher level uh thinking on this. Okay, let's get into the first part I'd like to find out about. And I hope the listeners will find this very interesting. And I've always been sort of a doctor, observer, watcher, like traits of why someone goes into a certain area of medicine. That's also a lot of times the question I ask a lot of my guests. But I think you would agree that brain surgeons aren't born, but they're made through a lot of hard work. And unlike athletes who can be blessed with either a great physique or great coordination, what are you what's your opinion on the traits that you feel are critical to becoming an outstanding brain surgeon?
Although brain surgeons are made, we're very self-selecting in a way because there are not a lot of applicants for brain surgery residency spots. There are very few spots in general, maybe 250 spots, and there are only 400, 450 applicants, which is a really small pool of medical
It
students
is,
coming out
yeah, yeah.
who are willing and want to make the sacrifice. So I think one trait that we all have is this notion of saying, I know that the training I'm about to undergo is brutally difficult. I'm going to have to sacrifice a lot of myself, of my free time, for the well-being of another human being, and to learn this skill. So that has to be there, in your essence. I think brain surgery is very much a caregiving field, just like all fields of medicine. It's not just a technical field where we're teaching ourselves how to manipulate the brain and the sort of the fine dexterity of the surgical movements. That's definitely a part of it, and it's a very important part of it. But you also have to really want to care about taking care of human beings at a moment of deep need and have an enormous amount of sympathy and compassion at the same time. I write about different traits that I see among neurosurgeons. Some are musicians, some are athletes, some are
I wanted to
just
ask you
sort
about
of,
that. Yeah.
yeah, scientists who love research and love thinking about how the brain works. Many of us are a little bit of all of those things, and
Right,
not just one category, because we
right.
all have multiple interests. Some have parents who are neurosurgeons, or some have lost loved ones to neurosurgery or themselves been touched by, surgeons and
That was
people
like
that.
Kevin Tracy. He was one of my original. I don't know if you know him. He was one of my original interviewers. He was a neurosurgeon. He was at Cornell, but he became a huge researcher in the field of what we call electric medicine. I mean, the
Yeah.
connection between the vagus nerve and autoimmune disease. But he talked about how he ended up becoming a neurosurgeon because his mom died of a brain tumor when he was just an infant. So
Yeah,
it's
we
fascinating.
see that a lot. That was not my
Wow.
particular story, although my
Yeah.
father was a Freudian psychoanalyst, so
Right.
that
I
got me
remember that.
interested
Yeah.
in the brain and the mind and how the brain worked for sure.
Mm.
But I didn't have an illness like that until after I was fully trained. And I do write about taking care of my parents
Yeah,
in the book
we're
about
gonna get
that
to
and
that. That
other
was very
but
interesting. But I guess what I was like saying, it's really funny. I don't know if you experienced this, but like when we were in medical school, it was typical like the people that were kind of bordered on arrogance, the bold ones, the cowboys, the daredevils say, "Oh, these guys are gonna be the surgeons." They like to ride motorcycles and fly airplanes. That was like the myth. But would you say that? I mean, I got the sense from reading your book, as you mentioned, like maybe even a marathon runner or a concert pianist, somebody that's got perseverance, that's in some ways meticulous. Those are the things. I mean, again, if again, I'm sure even at your center when you're deciding to hire, new residents or fellows. I mean, like, it's not just that they're smart. I mean, that's kind of like a given, like, but what else is it that they're going to bring to this very intensive training? Like, and as you said, there's really a small number of them. So it's like, God forbid, COVID knocked out half of the neurosurgeons, God forbid, it's a crisis. And it leads to the follow-up question, but I want to get to after, like, again, really, why are there so few? Is there a self-constraint? And, obviously I know the training is so rigorous, but as you mentioned in the book, think about it. There's so many community hospitals that could really benefit from having a neurosurgeon, not just some more, primary care doctors or physician assistants. I mean, when someone comes in with a brain bleed or something like that, I mean, you need somebody that can do that kind of work.
yeah, there's a couple of points you've made there. One
Yeah, I
has to
know.
do
So,
with the distribution of surgeons in the
hmm,
country. The first point, though, is that ability for sustained focus, right? You see, we're in long operations that
right.
last for hours and hours, and you have to be willing to sit there and not do anything else. And the more you do it, honestly, the more relaxing the whole experience can become. I find it like mindful meditation, where you're just completely present in the moment. You're in a flow state where you're not really thinking about the external world. Everything else is blocked out. Assuming things are going very well, obviously there are
Yes.
moments
We're gonna
of
get to that,
stress,
right?
yeah, where things can go badly, and then you're not so relaxed. But for a lot of it, it's this sort of slow, meticulous dissection that you do. At least once you get under the microscope. Getting under the microscope is another matter because there's a lot of carpentry involved getting through the skull. But the sustained focus is extremely important in terms of the distribution of surgeons and where the surgeons are. We tend to have too many surgeons in big cities and not enough surgeons in rural areas, particularly neurosurgeons,
Right.
because there's a lot of volume there. We tend to get paid better in big cities, and we don't have enough neurosurgeons in our rural communities. And so some patients who have head traumas in the middle of North Dakota will have to get on an airplane or a
Right,
helicopter.
right, right.
And those minutes can be life
Do you
threatening.
do you need like special teams also? I mean, I would assume you do. Like, I mean, we all know in all of our kind of practices, obviously the more specialized you get, you really depend on a lot, again, your technicians and assistants sometimes also, or is that not as important? You know what I'm saying? Like if they plopped you down in Kentucky and they said, Dr. Schwartz, we really need you here. You have to spend 6 months here. But like again, you were working like almost solo and having to train a new team. Is that
That's a big factor.
it is a big factor.
Neurosurgery is it's a team sport, right? So that yes,
Mhm.
there is sort of a captain of the team,
Right.
but we work very closely with OR techs and circulators and assistants who know us and they know how to hand us the equipment that we need. They know exactly what equipment we need. I've had the experience of operating in other countries, in India, and in
Oh,
Mexico.
oh wow.
And in India, the equipment is completely different, and there's a language barrier. Although many do speak English, in Mexico, I speak Spanish fairly well, so that helped me. But when you're in a foreign environment where you can't speak the language as well, you don't have the equipment you want, it's
Hmm.
extremely challenging to do neurosurgery. And a lot of those places will want to fly you over. They'll say, "Hey, can you fly over to our country and do a bunch of cases? We have these complex cases." And
Right.
I'm very reluctant to do that. As much as I would love to take care of the people and I'd love to train the surgeons there, I worry that without the right equipment, the outcomes are going to be substandard. And if I'm not used to it, I won't be able to be my best. I won't
I
be able to
get that.
perform my best.
No, it's
So
like you
I
need your
tend,
team. Yeah. And also like
yeah,
having your team, the people passing you the instruments the way and stuff like that. Yeah.
absolutely.
You talked about in the book too. I found this very interesting. Um, as doctors, and I know also when I go in the room with the patient, I'm trying to bring it all, so that's why I try to take really good care of myself. But look, there are days my back hurts or something maybe emotionally bad happened, and I have to tune that out. And I loved in the book where you went into, because I find this fascinating. Like you mentioned how, like, you have your routine before the surgery. You get up at 4 a.m. And, I'm sure you don't always, I don't know, I guess you don't always sleep as great. And the night before, sometimes you're reviewing anatomy. And then you do, even once you're getting into the OR or whatever, special breathing to minimize your hand tremor, whatever that, or steadiness, I should put it better that way. Is this commonplace, would you say, for a lot of neurosurgeons, to execute flawless
So I think it's important
surgery?
to distinguish between complex neurosurgery and some of the more simple surgeries we do. So there are some days where I'm doing a couple of small cases that are not that complex. I'm not waking up super early and anxious the night before. I'm not reviewing the anatomy. I've done the surgery, hundreds of times.
Hmm.
But there are other operations, and not infrequently, if you have a practice that focuses on complex skull-based surgery or vascular surgery, where you are worried and you're not exactly sure what you're going to encounter. The MRI scan only shows you so much of what you will be able to see. And you don't really know what you're going to find until you get there. Sometimes you'll see a vein stuck to the back of a tumor, and you're sort of saying, well, how stuck is that vein going to be? Am I going to be able to dissect that off, or am I not going to be able to dissect it off? And if I try too hard and I'm a little too aggressive and I damage the vein, the results could be catastrophic.
Right,
If it happens to be a very soft tumor when I get in there, then it'll come off easily and the surgery will be quite simple. But a surgery could be 3 hours long and it could be 9 hours long, depending on the consistency of the tumor, whether it's soft and suckable or extremely firm. And you don't really know that until you're in there at the moment of surgery. And I write about that sort of constant
no, it was
decision
interesting.
making that we do, where I sort of likened it to driving to work in the morning, where the Waze app, you think you're going to go a particular way, but then there's a road closure and there's a flood and it was raining and a tree fell down and you have to reroute. And that happens during surgery as well, where you come up with a plan A game of what you're going to do, but very often we have to recalculate and reconfigure our approach and redo things on the spot, which is what makes it so fascinating and so interesting, because there's so much decision making that you have to do at the moment. And yes, you have to prepare for it. I try to stay in shape. I try to go to bed
Well, I was gonna say, I
early.
mean,
I
like
try to,
honestly, let's say, look, God forbid, whatever, your shoulder hurts, you were playing tennis the other day or golf or something like that too, and this, that too, and you're getting up that morning and you're having your coffee, getting ready. It's like, is it sort of like, I guess like a ball player. I mean, sometimes that's how I feel. I mean, I was a tennis player, so I found sports helped a lot. It's like game day, it doesn't matter what you're feeling, you got to perform. Is that how the the mentality is going into
Yeah, it's very
obviously.
much like that. I mean, a lot of the aches and pains you block out. We don't go to the bathroom. We don't, we don't,
Yeah,
I
I mean
don't feel,
hours, right? You can't
yeah,
scrub out.
I don't feel my back pain until I'm done with the operation. And then suddenly I realize,
Mm,
wow, my back really hurts and I start stretching. But
mm,
like during the course of the operation, you're not really thinking about it because you're so focused on
yeah,
what you're doing at the moment. And of course, we have routines like, going to the bathroom before you head into the OR. Like that's just, I don't even think
yeah.
about that.
I
On
know,
the
but it's
way
like
in,
so
I know I'm gonna do,
important,
yeah, for sure.
Let me ask you this too. It's interesting. I can't believe how old this magazine is that I saved. This was from a New Yorker in August of 1999. Because when I read
Show me.
something really, August 1999, a New
Yeah.
Yorker article. I just want to tell you briefly because, and you'll see the relation to what I want to bring up. Actually, Malcolm Gladwell, who's again one of my favorite writers, and he was writing a lot more articles than before all of his books. And the article was called Action Einsteins: Why Some People Are Physical Geniuses. And in the article, he talked about a couple of ball players and everything, but then he talked about a Dr. Charlie Wilson. Did you ever hear of him? I'm
Well,
not sure if you.
I've read that article and
Oh,
I've
you
met,
did?
yeah, and I've met Charlie Wilson. I
Oh, you
interviewed,
have?
yeah, he was
Wow.
the chair at UCSF.
That's
When I
right.
was a resident, I interviewed with him.
Oh, wow. That's incredible. So in the articles, then, and I found it fascinating. He talks about physical geniuses. And what I found very interesting, it was crazy, how typically Charlie Wilson, I guess, on runs before he would go to the OR or whatever, he used to visualize the whole operation in his head before he went in. And again, you may have not, I just reread this. I hadn't read it for years again, too. And one of the most incredible parts of the story where he was operating on somebody and, did his whole thing. And then he scrubbed out, while the other assistants were, I guess, closing up. And then he remembered in his visualization an area that he didn't think that he checked. So he scrubbed back in. And sure enough, there was like a little clot or something that he had to take care of. So I was again curious too. I mean, since this is such a important area of where you have to have such amazing visualization, that do you do anything like that in
Yeah,
preparing for your surgeries?
yeah, just a bit on that article. I
Yeah,
love
because
that
it was
article because
great.
he talks about Wayne Gretzky and seeing the
Yes,
ice, and he talks about Yo-Yo Ma and
that's
the
right.
idea of having physical genius and the visual spatial. He called it chunking, where you kind of put a
Mm,
lot of bits of information together all at once. You don't have to go through it in the same meticulous way, but um, we very much visualize what we think we're going to see when we go in there, and we visualize the route. We see the danger that we may face in different areas. We know where there are going to be problems. So, for example, if I'm looking at an MRI scan, I'll see a nerve or an artery, and I'll say, well, it's going to be on the bottom left-hand side. I know I've got to look for it there. That's where I'm going to find it. And as I'm operating, when I'm in the bottom left side, I'm looking exactly for that thing. And if there's a knuckle of tumor, for example, that I know is heading out, the top to the right, when I'm operating, I'm looking for that little knuckle of tumor. And if I don't see it, I keep looking for it because I know it's going to be there. I know I have to
mm.
find it if I want to take it out. So we have to create that 3D representation in our head, and the better surgeons can do that more quickly and more accurately. We now have virtual reality goggles that we can wear that
Oh,
allow
that's
us
really
to
cool.
create a
Wow.
3D
Yeah.
reconstruction. They're still not that
Yeah.
common, and we don't do them that often. And it's a bit of a hassle to sort of have the MRI scan digitized in the right way to do it. So it's still a skill that's much more value if you can do it on your own.
Yeah.
But those 3D reality, virtual reality goggles, I think are going to make a big difference with training once they're easier for us to use.
It's interesting. That same article too is Dr. Bennett Stein, who maybe again you interviewed with or whatever. He was like chairman of neurosurgery at Columbia, and he said one of the reasons some neurosurgery residents fail in their training is that they're incapable of making the transition between the way a particular problem is depicted on an X-ray or MRI and how it looks when you encounter it, obviously in the real
So,
situation.
so Bennett Stein was my chairman. He was the one who selected me for my neurosurgery residency. I trained at Columbia.
Oh, you did train in
Uh,
Columbia, yeah. Well,
I
there.
did, yeah. So I
Oh,
knew him
interesting.
very
Yeah, I did
well,
train there. Uh-huh.
and he had a remarkable ability. He would bring us in on Saturday mornings, actually, when we thought you had the weekends off, but that's when you would have Stein conference, and you would all come in Saturday morning, and he'd show MRI scans, and he'd pick on the residents, and he'd start pimping us, asking us questions about, what would you do, how would you position the patient, and then he would sort of say, "Hey, why don't you come up here and draw us a picture of the brainstem?" And he had the ability to draw the brainstem with a pen in each hand, and he would draw it with two hands. He was
Oh,
ambidextrous.
wow.
Yeah, and he had an incredible knowledge of anatomy. That was one
Huh.
of his strengths. He was a remarkable surgeon and a great teacher.
Wow. You know, I read something also too, and I don't think it was in this article. It might have been a different one that either Malcolm Gladwell wrote or Atul Gawande. And it was very interesting. I guess they were doing like research on surgery residents. I don't know if it was particularly neurosurgery, but it was surgery residents. And they were curious to see uh, which ones made it to the end, you know, because as you know, and I don't know if it's the same in neurosurgery, but in a lot of general surgery programs, there's like a pyramid program, as you're well aware. And some of the people don't make it. So the psychology researchers were curious if they could detect anything that made someone make it to the end. And this was interesting. One of the few things that they found was that when they were interviewing the different um, residents, the ones that tended to say, when they said something like, "What happened in this surgery?" And if something went bad, "Oh, you know, it was a very bad case. We had no chance." Or, you know, they didn't prep the patient right, and that's why that happened. You know, it was like an excuse. Whereas the other ones who ended up succeeding, it a lot of them would say, "Yeah, you know, it didn't work out, but if I had to do it over again, I would have, you know, done something different," meaning that they were reflective on their, um, you know, on getting better, I guess, essentially. And so that kind of leads me into my next question too about skill level. And you talk about this in the book. And again, I'm one of my favorite writers, Malcolm Gladwell, who wrote his book Outliers. He based it on, as you're probably aware of, I think it was Anders Ericsson, that 10,000 hour rule, meaning that it typically takes in most fields 10,000 hours of skilled practice before you really master something. Now, in neurosurgery, it's probably a little bit easier because they make you go through about 7 years of residency. It's not like you take a 6-month course and you're a neurosurgeon. But you mentioned in the book something a little bit scary, but I'm sure true, that it takes then another 5 years of like when you're in your own, you know, no longer in residency to really be skilled. Can you explain to the listeners who haven't maybe read the book yet about that? Because I found that interesting too. Because again,
Yeah.
look, everybody eventually has to be, you know, it's year one outside of residency. You're the neurosurgeon at X hospital, and you got to do the job. And you
So
discuss this in the book a little bit
yeah,
yourself. You know,
Dean, it's even scarier than that, to be
it
honest.
is. Let's
It
get the
is,
audience really involved. They kind of
yeah.
know that, you know.
Well, it is and it isn't. So
Okay.
there's good news and bad news. I'll put it that way.
Okay.
I don't want it to be
Okay.
all negative, but
No, I'm joking.
you know, you see a certain number of surgeries when you're a resident, and you get a lot of exposure, and you see things again and again.
Hmm.
But there are some things that are so challenging to do. There's some moves in neurosurgery that are so risky that as a resident, you may never get to do them because the attending just will never be comfortable letting you, you know, put the clip on the
Sure.
basilar tip aneurysm or, you know, peel the last bit of tumor off the facial nerve that will paralyze the patient's face, you know, if you're a little too aggressive. And so those things you will never do until the first time you do it will be when you're in charge. So some of the surgeries you're doing as a junior attending, you're essentially doing some moves for the first time. And I wrote a paper a couple of years ago where I looked at my results over 1,000 consecutive types of cases. It's one type of case that I had done 1,200 of. So I left the first 200 out. I looked at the next 1,000 and I divided them into quartiles, 250, 250, 250, 250. And I said, what were my results? And this is over a span of 20 years. And my last quartile was better than the quartile before that, which meant that I was a better surgeon 15 years into my out of training, 15 years into my career than I was 10 years out, than I was 5 years out. And so
Wow.
I think a surgeon, when for the most complex operations that we do, you continue to get better throughout your entire career. And the more you do it, the better you get. So it's not just 5 years out and then you're perfect, but it's even 10 years out, you're getting better, and 15 years out, you're getting better. And the scary part for what society wants and needs and what the fact is that society wants our neurosurgeons to be fully trained when we're done with our
Yeah.
training,
Right. Right.
know exactly what we're doing. At the same
Right.
time, when I'm taking care of a patient and they say to me, well, you have any residents helping you? I want you to do my whole case. I want you to do it. And I say to them, yes, I will do, your case. I'll do the critical parts. So they both want the trainees not to do anything when they're training. And then they want them to emerge fully trained and perfect at the end, right? And those
Yeah.
two things are mutually incompatible. It's
Right.
impossible to do that. And
Yeah.
so the challenge, of course, is to give the trainee enough responsibility as they're going so that when they get out, they're competent, but not too much that they hurt any patient along the way. And that's really the challenge of being at a teaching program.
It is. I actually want to bring up a point about that, but just to harp on one more thing too. So, would you say that you're also better after all these years, obviously, besides the experience, the confidence? I mean, sometimes if you get into a tough situation that you're like, okay, I've done this before, like you know how to steady yourself and
That
see
works
through
both
it.
ways. It
Yeah.
works both ways because sometimes you can be overconfident as a
Mhm.
younger attending and bite off more than you can chew because you
Right,
feel like
right,
I should be able to do this
right,
operation. I
right.
should be able to get the same
Well,
result that I've read about in this article about this
yeah,
new approach. And so I'm going to try it, and your results can be suboptimal because you're not ready to take on such a difficult task.
yeah,
So it goes both ways. Yes, we have more confidence. I definitely have more confidence now. But the thing about confidence, it's a funny thing in neurosurgery because no matter how good you are and no matter how experienced you are, you will still have complications. You will still have
yeah.
cases that go south. Now, it's not most of them. Obviously, most of our results are great. And if
Mm,
you go to a good neurosurgeon, you can expect a really, really good result. But no matter how good you are, there's a certain percentage, could be 1%, could be 2%. And if you do enough cases, 300 cases a year,
yeah,
it's going to
yeah.
happen a couple of times where things don't go perfectly.
That's why I don't like, I really hate that whole ratings thing, when they come out with the rating the surgeons, it's an awful thing. The public doesn't realize this because, one of the things too, like I sometimes try to explain to patients and everything too, like sometimes you'll see, I don't want to name a hospital, let's say out on Long Island has 99%, cardiovascular success, bypass, and Columbia is like two below because they have 97%, not realizing that that other hospital is not taking all takers or the most complicated cases,
Right,
and
for sure.
right. So that's
But the
like,
thing I wanted to mention, just the last
yeah.
point about
Hmm.
confidence, is you also you have to maintain your humility along the way
Hmm.
because if you're overconfident, you're going to hurt people. So
Right.
in every case that I go into, as much as I've been doing it for so long and I've had so many great results, I'm always thinking to myself, something could go wrong here, and I cannot lose my focus for a second. Like
Right.
you said, what was the subtitle to the book? You
No room
can't,
for error.
no room for error, right? So I'm thinking that in every case, even the routine cases,
Yeah.
I'm still thinking like there's stuff that can go wrong here, and I have to be vigilant from beginning to end to prevent that from happening.
Yeah. We're just going to take a quick break and we'll be right back. Dr. Schwartz, most people would be surprised at, as I mentioned in the introduction, of how primitive brain surgery was when it originated. I think those early surgeons, like Cushing, who's a very famous, Harvey Cushing was a very famous brain surgeon, but in some ways, it was barbaric what they did or how they tried to do things. And I think most people would be so surprised that like today, obviously, like as you mentioned, using a microscope is routine in practice, where back in the day it was all the naked eye. Can you tell us a little bit how, and you talk about this in the book, how neurosurgery changed? Was that a big advancement, obviously, in
There have been
doing?
numerous revolutions in neurosurgery. I don't know if you ever saw the TV show The Nick that tried to show a little bit about primitive surgery. Oh, you should watch that. It
That's
kind of
good.
shows
Yeah.
the barbarism of what things used to be like. And
Yeah.
even anesthesia, Cushing got his start giving anesthesia to patients when he was a medical student. And the first patient he anesthetized died on the table because he gave them too much and they didn't really know what they were doing. When he
Wow.
started doing neurosurgery, and that was the turn of the century, 1900, 1905, around then, the mortality from brain surgery was 50%. So half the
Wow.
patients who went under the knife died on the operating room table or soon after from an infection. And at the end of his career, it was down to 8%. And you
Hmm.
can imagine how stressful that must have been for him. And many of his teachers thought he was crazy to take on such a difficult task. Why would you want to go into a field where half your patients are going to perish? How do you deal with that emotionally? And he was a tough guy. He was very tough on his trainees, and obviously he was
Hmm.
holding in a lot of stress and emotion. He was addicted to cigarettes also, and died of earlier than he should have because of the health related
Hmm.
illnesses related to the cigarettes. But When he started out, he would operate in a room with a lot of windows so he could see what was going on. And then people had loupes, magnifying glasses attached to your glasses. And then the microscope came in around the 1950s. A neurosurgeon named Gazi Yaşargil, who was a Turkish neurosurgeon who was practicing in Zurich, brought the microscope into neurosurgery and really revolutionized the practice of surgery, where surgeons could now see what they were doing on a millimeter scale level, whereas before that they couldn't see things, and surgeons would say ridiculous things like, any blood vessel you can't see with your eye is probably not worthwhile, which we now know is completely not true.
Mm.
All those blood vessels are extremely important. And then there have been multiple other revolutions in neurosurgery. And I sort of go through each one of them, the development of stereotaxis and endoscopes and radiosurgery and focused ultrasound and, interventional neuroradiology. So many different techniques have been introduced to the modern practice of neurosurgery to make it much safer and much less invasive.
I'm just curious too, because I know like when I've done a little bit some like endoscopies, like with nasal stuff in the past too, and then when I was in training, they were transitioning to watching it on TVs and cameras. But it was a big leap, and I can't imagine in surgery of taking your eyes off the field and watching a screen. Do they have that like in neurosurgery, like where you're actually working on the brain, but you're looking at like a big monitor?
Yeah, so that's one of the things that I started doing well before many other neurosurgeons, which is to operate up the nose to take out brain tumors using an endoscope.
Right, you
And in
mentioned
that
that.
surgery, the ENT surgeon will go in and sort of create a corridor for us through the sinuses. And then we do the rest of the surgery and can go very deep into the brain, going through the nostrils. And in that situation, you're looking up at a screen. You have to put your hands in the right place to get them, into the nostrils. But then the whole surgery is with your head looking up.
It
It's
is.
actually it's
Wow.
actually better ergonomically for the patient's neck because a lot of surgeons will have neck surgery because they spend their entire
Oh yeah,
career
they were all
looking
like this.
down,
Yeah,
yeah, with
right.
loupes and headlights weighing down their
Yeah,
head.
yeah,
You
yeah.
do endoscopic surgery, you're looking straight ahead at a screen. And I think it's helped me preserve my spine
Oh
longer,
wow.
that about a third of my cases are done, with my head looking straight ahead.
Hmm. All right. I want to talk a little bit um, before we get into some of the operations, sort of the personal and emotional toll of being a brain surgeon. As you mentioned so poignantly in the book, you were rushing to try to save your own dad from the complications of a stroke. And I thought that was, so touching. And you actually mentioned that there are, new interventional procedures now, like to remove clots and stuff like that too. But I was just curious, coping with the loss of a patient or a bad outcome, again, to make the ball player analogy, a guy loses a championship, whatever, it's devastating to them and that level. They obviously, have to pick themselves up and go on to the next game, the next tournament. How do you try to cope with if something unfortunate has happened or there's a loss, again, that had nothing, you know, due to your skill, but it just happened. You're dealing with a very, dangerous area.
Many of us surgeons are devastated when things go badly with their patients, and those patients stay with you forever. You never forget them. You see them at night when you go to bed, you see them in the morning when you wake up, you think about them. Every time you do a similar operation, you're thinking about that patient. Um,
Mm,
and but the thing is, we have to erect what people have called emotional armor, which is to say, although I'm feeling this at the moment, I have to put it on a shelf for a little bit because I have another patient coming in who's
right.
depending on
Who
me and
needs you? Who needs
who
you?
needs me
Right.
to
Yeah.
perform my best for them. And I owe it to them to do my best. And I owe it to the patient, obviously, that where maybe it didn't go well, to honor their memory by doing my best again and making sure that I learned from it. But it's very difficult and something that I try not to bring home. But I'll tell you, my wife knows when I come home
It's
and I
been a
haven't had a
tough
great
day.
day. And it's very hard when you have children. You're trying to sort of stay optimistic and positive for your kids.
Mm-hmm.
And obviously, the older your kids get, the more you can share certain things with them. But we have to erect emotional armor, and then we also have to have emotional flexibility because we can't be robots, right? We can't be
Right.
emotionless, feelingless robots when we deal with patients because we also have to be very sensitive. And
Yeah.
then it's also about dealing with the family and dealing with the patient
Wow.
after something like that happens because you have to be emotionally available to them. You have to show your vulnerability. I feel, to them. Like they don't want to know if, God forbid, something goes wrong, that you've just moved on, like
Right.
that you're not thinking
Right.
about it anymore. Because
Right.
the truth is, you're not.
Right.
I feel very comfortable showing that and sharing that. And honestly, some of the most emotional experiences I've had in my career have been when I've opened up to patients and their families and literally apologized and said, hey, I failed you at this moment, and
Mm,
there's nothing I can do to make it better, but I share your grief and your sorrow. But the good news is, again, the majority of our cases go so well, and there's so much
mm,
joy and pleasure, and there's so many
mm,
hugs that we get from
mm.
grateful patients. And you have to try to think about your victories as well as your occasional failures. But
100%.
no, usually you remember the failures much more strongly than the victories, even though they far outweigh them.
Yeah, that's probably true. I was just curious, in neurosurgery, is there any camaraderie among the surgeons? Again, when you were writing about Cushing's, he sounded like he was kind of a nasty guy. He was very competitive and didn't treat his own associates very well. And, you would think in medicine, I mean, it is kind of back in the day, probably when we trained a little bit of the atmosphere. I don't know if anything's changed really, but you'd think that in people like yourself who've dedicated your career, that to be able to at least to share with somebody else who only can know what you're feeling because they do the same work. Is there any type of, like in meetings or something where, people kind of let their guard down and
First of all, neurosurgeons are very competitive. So I'm going to
they
speak to
are?
the first question. Yes, because we're all trying to be the best. We all think we're the best. We're all trying to convince ourselves and our patients that we're the best. And we're all looking over our shoulders at what other people are doing and comparing ourselves to others. And there are some surgeons who really are not very soft and fuzzy, as you know. And I've worked for a lot of those, and you don't get a lot of emotional support from those types of surgeons. On the other hand, there are other surgeons who are just wonderful human beings, and you can open up to them and share with them. So I have some very close friends that are neurosurgeons who I can talk to about what's going on in my life, and I can share it with them. And then I have many other who I would not tell a single thing to, because I know that it would.
You can't
I
show, you can't, you have to keep that body armor on.
Right, right. So it really depends on the individual.
Yeah, that makes sense. All right, let's talk a little bit about some of the operations because it was really interesting. I mean, I was learning things too. Well, first of all, how is it that in brain surgeries patients could be awake? I mean, they have. I mean, obviously, like as you say, to get through the carpentry, to get to the brain, you got to do stuff. So, tell us how that is, and also like for what kind of procedures would a patient be awake? Would it be like for epilepsy where you're trying to find the focus? Would it be for a brain tumor because you don't want to damage some other thing that they're speaking? Maybe you could like
Yeah,
explain
so
to us.
there's the why and the how, right? So the
Okay.
why question is when you are operating on a part of the brain that's very close to another part of the brain that is critical for a function, like moving the hand or for speech in particular, you need to map the brain. And the way we map the brain is we stimulate the brain with an electrode. And if you stimulate a part of the brain that moves the hand will move. If you stimulate the part of the brain that's important for speech, and you have a patient who's actively speaking or interpreting speech, you will block their ability to do that function. And you will know that that particular part of the brain is critical for speech, and you cannot disturb that, or they will not be able to speak. And sometimes when we're taking out tumors, we don't know where those parts of the brain are that are important for language. And unless we map the brain, and that can be a tumor or it could be epilepsy, those are the two most likely reasons we would do that. We have to have them awake and speaking in the operating room. How we get that done, uh, patients are not awake for the entire procedure. If you get a colonoscopy, for example, you get IV sedation and you're asleep. You don't remember your colonoscopy. So
Right.
they're essentially that asleep when we're opening up the skull and the skin. We give an enormous amount of local anesthesia to the skin and the scalp so
Mm-hmm.
they don't feel that.
Right.
But the brain itself has no pain fibers.
Yeah,
So
that's
you
incredible. I think that's what people can. Yeah, it's like hard to imagine, like touching the brain, whatever. Too, they don't feel
you
even
don't
if
feel it.
you don't feel anything. Yeah.
You don't feel anything, right? So we keep them very comfortable, and then we just wake them up for a brief period of time when we need to do the language mapping, and for the rest of the procedure, they're asleep.
Mm. You also talk about, first of all, you talk about a lot of interesting, famous people that their medical history is known, like Joe Biden with his aneurysms. People don't know. I mean, the guy's been through a hell of a lot to get to this age. Like, for a lot of reasons, I admire him.
He had two aneurysm
Two
surgeries.
aneurysms. I know, right? Once he
Right.
had one, then they knew he had to go back another 2 months later and have another brain surgery.
And
So,
his surgeon only has one eye and
right.
never graduated from college. And he's one of the most talented surgeons of his generation. So
Wow.
he was that good that he only needed one eye to be a talented
That's sounds
vascular
scary.
surgeon. Yeah.
But regarding, I guess, clipping brain aneurysms, I make the analogy for certain things in my practice, but yours, it really is, I think, quite appropriate. Doing like clipping an aneurysm is like sending in the bomb squad to defuse a bomb. So maybe explain to us a little bit too, again, what's entailed with that. What are you spot patients having symptoms. They have it's either incidentally found or they're having terrible headaches like President Biden was having. And then you got to go in there and essentially, I guess, clip this vessel or
Yeah, so
remove it and graft
I'll
it.
take you
Yeah.
through it a little bit.
Yeah.
So
Yeah.
an aneurysm is basically a weakening of the wall of an artery
Mm-hmm.
that first starts out like a little bleb, like when your tire hits the curb and you get a little bleb. And then the
Uh-huh.
pounding of blood hitting the aneurysm makes it gets bigger and bigger and bigger until it turns into a full bulb. It literally looks like a head with a
Yeah.
neck.
Yeah. I've seen
Right.
I've seen on
Someone's head,
X-rays and
right.
MRIs.
So,
Yeah.
and if the sometimes those are picked up incidentally. So you do an MRI scan, you say, oh, there's something on an artery. We get a CT angiogram, and sure enough, there's an aneurysm there. Sometimes they leak a bit of blood, which is called a sentinel bleed. You get a very, very bad headache, but it's not a full rupture.
Mm-hmm.
So they can be awake and alert and just say, I just had the worst headache of my
Mm-hmm.
life. My headache's terrible. And I talk about a friend of mine where that happened, who I took care of him. And sometimes they'll all out rupture, in which case you can essentially lose consciousness, have a seizure, and 50% of people who have a full rupture will die from their aneurysmal rupture. So it can be extremely dangerous.
Right.
So there's two ways to treat aneurysms if they need to be treated. The traditional way is to do a craniotomy. You open up the skull, and you go down to the aneurysm and you put a clip across the neck of the aneurysm. So remember I said it looks like
Mm-hmm.
a head.
Right. So you're
And so
clipping the neck
you're
kind of
clipping
thing.
the
Yeah.
neck, right? So you're cutting off the aneurysm from the blood flow.
Right.
And that is essentially a cure of
Well,
the
how do you,
aneurysm.
but then do you have to like what they call anatomize or like bring together the other two parts of the vessel? I mean, how does the blood still flow through?
So it comes at a junction point. So you have to put the clip in such a way that you keep the blood vessel open when you
Right.
put the
Yeah.
clip down. That's really the
Oh.
art of it. And there
Oh.
can
Oh, I
be
see.
a lot
Okay.
of very small blood vessels passing around
Yeah.
the aneurysm, and you have to keep all of those open. So we'll use a fluorescent dye. We'll do like a fluorescent angiogram during surgery to make sure
Uh-huh.
that those blood vessels are all open so we don't crimp them off when we're putting our aneurysm clips on. But if an aneurysm ruptures during surgery, it's extremely stressful. It's extremely dangerous. The whole operative field fills with blood. You're looking under a
Uh,
microscope. You can't see anything but blood.
uh,
And you very rapidly have to put a big sucker in there, get the blood evacuated, and then put temporary clips, which are little clips on all the arteries that are feeding the aneurysm, because the aneurysm is
mm.
basically a hole in the blood vessel. So you have to isolate it from the circulation. And so that takes an enormous amount of technical skill. You're working at the bottom of a very deep hole under very intense magnification.
Mm.
And if you can't get control of it, the patient will die. So
Yeah.
everything is on the line at that moment, and the surgeon's
Mm.
skill is what's keeping that patient alive. But we now have another treatment, which is to put a catheter up into the artery. And you can do that through a needle stick in the wrist. You can do it with a needle
Mm.
stick in the groin
Crazy.
area.
Wow.
Thread the catheter up with X-ray guidance. And then once you're in the blood vessel, you can release these little magnetic coils into the aneurysm, electric coils, and they're metallic, and it'll cause the aneurysm to thrombose. So
Mm.
blood can't flow through it. So you
Does
don't
it
have to open
usually
up the heart.
last? Because it sounds like obviously with Biden, he's been fine. I mean, like even with the clips, I mean, is it like hopefully a cure for a lifetime, or do you have to
Yeah,
still always worry about,
it's a
you know?
lifetime cure. You still follow it. Sometimes
Hmm.
the clips can slip a little bit. Sometimes
Mm.
if you don't have the clip in just the right place, the aneurysm can reform. And once you have one aneurysm, you're at risk of developing aneurysms elsewhere, because whatever the disease is that led you to get the
Right.
aneurysm in the first place,
Yeah.
whether it's genetic or smoking or diabetes, those things are still going on in your body.
Mm.
So you
Yeah.
do need to be
Very
monitored.
scary. We're just going to take another quick break, and then we're going to go back and ask Dr. Schwartz what he thinks the future for brain surgery and the whole area holds. We're back, and I wanted to ask Dr. Schwartz about the future of brain surgery. So my question to you is this. Do you think it's been kind of obviously you have to, Elon Musk is in the news for a lot of reasons, whether it's Twitter, X, or whatever else he's doing. But he's like pretty big on this brain stimulation and that he's going to get paraplegics to walk again. Do you think we're going to see this area of medicine with this, I guess, brain stimulation and whether it's the spine or the brain that will potentially reverse paralysis in our lifetime?
Yeah, I think most people don't realize how far advanced this technology is. Elon is not, he's created a remarkable device, but he didn't invent the brain-computer interface. The brain-computer interface has been around since the 1960s, and
Oh,
there are in academic institutions all around the country, scientific laboratories that have been using brain-computer interfaces and implanting them in patients and allowing patients just by thinking to move robotic arms or to control computers or to move robotic legs or to speak. A patient who doesn't have the ability to speak anymore can literally think of what they want to say and think about moving their lips and their tongue or moving their hand to write. And that information can be taken out of the brain just by recording the electrical impulses of the neurons, sending it into a computer, teaching the computer what each of those impulses is. So which impulse is an A, which impulse is a B, which impulse is a C, and linking the two to take ideas out of the brain. So all that technology already exists. He's just created a device. It's got a slightly new technique to it where he's essentially sewing these little threads into the brain that hasn't been done before. But we've put small electrodes into the brain and on the brain to create brain-computer interfaces. So I think it will be very successful. His company is not the only company. There are going to be 4 or 5 companies out there competing with Elon using different techniques that are coming to market soon. It's just that he has so much money and so much exposure and the
right.
voice of X, and journalists that everyone knows about what he's doing. And he's very much ahead of the field in terms of commercializing a brain-computer interface. But there are other people at academic institutions who are far ahead of him with respect to what they've been able to do with their brain-computer interfaces.
Do you think at some point that like people that are paraplegic or whatever to may be able to walk again with some of these things, or is that too
Well,
far-fetched
so
at this
there
point?
is a way to do it, but so there's two different techniques for doing that. So one is to let's say inject stem cells into the spinal cord so that someone can walk again. That's a totally different technology. But what you could do is take the signals for moving the legs out of the brain, and you could stimulate the muscles of the legs with other electrodes to try to get the legs to work, or
Oh,
stimulate the,
wow.
the nerves going into those muscles, or the bottom of the spinal cord if it's still alive, to take the information and basically, like a jumper cable, jump over the transection in the spinal cord and just reintroduce the information
Oh,
lower
wow.
down using electrodes and computers. So
Yeah.
that is technically feasible.
I've said this a few times on the podcast. I think medicine has evolved in sort of this sequence that um, it went from voodoo and whatever this crazy mystery like with the understanding anatomy, and that led to surgery. It then had that next evolution where chemistry helped us evolve into pharmacology. And as I mentioned with Dr. Tracy, I think the next evolution in medicine may be electric medicine, somehow harnessing, the power of, the electric stimulation between neurons or whatever that, may change medicine, but we'll see.
Yeah, there's a
Um,
book I recently read on exactly that topic. The
oh,
name is
really?
is elusive to me at the moment,
Oh,
but
okay. If you remember, let
there's
me
a
know. I love reading all that
yeah,
stuff.
I'll
Maybe I'll
send
bring
it
him
to
on the
you
podcast.
afterwards. Yeah.
We've covered so much today, and I really appreciate your time. Is there anything else that you'd like to mention from the book, or that you just think that we didn't cover?
Yeah, I think that part of the reason I wrote the book was the sense I had that the story of brain surgery really hadn't been told, and that people don't really understand what it is we do. We have this sort of myth of the brain surgeon when we say things, it's not brain surgery. So I really wanted to dissect that myth and say, like, where does it come from? What are the
Mm,
myths that we have? It's not just that it's something really hard, but there's also sort of the myth of the mad scientist and
that's
the
right.
Hollywood version of the brain surgery, brain
Yeah.
transplants, and talk about how that came out of the frontal lobotomy. And there's just so many stories and ways that brain surgeons have touched our culture and our society. And I really wanted to get to the heart of all of those things in a way that was a fun, easy read that people could digest, learn a tremendous amount about how the brain works, and what brain surgeons do to get a better understanding of it. And it was really like a love letter to brain surgery to me, because
Hmm.
I love what I do. I think it's an incredible job. And the ability to touch people's lives in the way we do is something unique. And I wanted to share that experience with other people.
Yeah, I was looking over your biography. I think your liberal arts education came in very handy because the writing was really good. I majored in English besides doing obviously pre-med in college, and it's served me well. But again, I want to, Dr. Schwartz, give you kudos on writing really a great book. Please, anybody interested, in the brain and medicine, this really is a really good read. Where can we send any of our listeners who want to just know any of the other kind of work that you're doing? I don't know if
I do
you
have a
know.
website I put together, TheodoreHSchwartzMD.com. There's also a whole research page on there if you want to know what kind of research I do, because I run a basic science laboratory as
Oh, you
well
do?
as,
Yeah. Well, all I know is thank God if I'm in New York, I ever need brain surgery, you're definitely going to be on my speed dial because not only are you obviously, you have the most amazing skill and qualifications, you're a really good guy too. So thanks for coming on.
thanks, Dean. I really appreciate it.